a tremendous honor for me because I get to reflect on one of my colleagues' amazing successes. So for those of y'all who don't know Jill or don't know her background, her educational endeavors were done initially at Penn State in undergrad and medical school, and then did her internal medicine training, chief resident, that sort of thing, at Georgetown. And I actually remember very clearly sitting in my office and interviewing her for cardiology fellowship and having her talking about interests in adult congenital heart disease that had been fostered going back to med school days at at the time, relatively unique ACHD program at Penn State. And then also talking about behavioral sciences, which was her undergraduate major, and wanting to find ways to marry those things. And the amazing thing about what Jill's doing now, and she self-articulates it, but I remember it back when she interviewed, is that she's now managed to find a way to take all those things that she loved about, as she says, studying medicine in the first place, with the unique lens of behavioral sciences that she really gravitated towards as an undergraduate and medical student, and now has turned that into a thriving career all of a year and a half into her faculty life. So while a cardiology fellow with us, she continued to be interested in adult congenital heart disease. We were lucky to keep her for her ACHD fellowship training. And then she joined Randy Curtis's T32 through the Cambria Palliative Care Endowment, and did her T32 in palliative care, and is now bringing this highly unique amalgamation of adult congenital heart disease and then sort of palliative care, but in particular, Jill has actually taken that, and her primary research is around resilience, which I think is an incredibly cool thing. And it's all well and good that I think it's incredibly cool, but it turns out that the rest of the country who has any knowledge of this space is really speaking volumes about the value of what she's doing. She has actually gotten a K23 award, and she got that on a fairly rapid turnaround, and is a funded researcher now with a couple of different grant funding opportunities. Actually, she had to turn a few of them down in order to be able to do her work. And she is being put on national committees and involved in national organizations because of her particular expertise in this space. So I'm really delighted to have Jill. She brings a ton to the division and to the adult congenital group with her unique interest. And she brings the passion that comes from somebody who's managed to find a way to do the things that they loved in the course of their studies. And like all the rest of the adult congenital folks, she has an appropriate fondness for outdoor activities and good food and unicorns and rainbows. And so I'm really delighted to introduce Jill, who's just been an amazing colleague and has had really unprecedented sort of success in this space in adult congenital heart disease. And I'm really interested to hear her talk today on telling us a little bit about what she's doing, but also the broader field as a whole. So Jill, thanks so much for taking the time.
And thank you for such a nice introduction. Good morning, and thank you all for the opportunity to speak today. I'm excited to talk to you all about incorporating palliative care into adult congenital heart disease as a way to help our patients live well despite illness. I have no relevant disclosures. These are my learning objectives for the talk. First, I hope that by the end of this, you'll be able to understand the value of palliative care in ACHD. I hope that you can define resilience and its potential impacts in ACHD. And I hope that I'm able to demonstrate the significance of palliative care and resilience research in this field. So I'd like to start by having you imagine two patients that you might see back-to-back on rounds. The first is Jem. Jem is 25. He has a Fontan repair for a tricuspid atresia. He had 4 heart surgeries before he was 5 years old. And now as a young adult, he has severe symptomatic heart failure and cirrhosis. When you ask him how he's doing day to day, he says, you know, it's hard for me to walk upstairs, and sometimes I get tired walking my dog. I used to work at a store, but I had to quit because it was too much for me. I try to rest. I know my heart has something to do with it, but I mostly try not to think about it, and I take one day at a time. And then your next patient is Alex, and Alex is 32. She has a bicuspid aortic valve with mixed mild stenosis and regurgitation. She's never required surgery for this, and she has normal heart function. And when you ask her how she's doing day to day, she says, well, it doesn't stop me from doing anything. I feel fine, and I think I'm pretty normal. I mean, if someone listens to my heart, I have to be like, oh no, it's no big deal. But yeah, I get it checked every couple of years, and outside of that, I don't really think about it. So I use these two as examples of patients who may look similar to each other when they're sitting side by side in the exam room or in the waiting room, but those whose lives may look very different, both in terms of length and quality as a result of their ACHD. As you may know, there is a lot of heterogeneity in ACHD in terms of anatomy, hemodynamic impact and disability, and life expectancy. Anatomy can range from heterotaxy with univentricular heart to a small isolated septal defect. Some of our patients struggle with heart failure and everything that comes with it. And some of them, I'm intentionally choosing the extreme here for this particular morning, are professional athletes. In some cases, people with the most severe anatomic disease also experience the most significant impacts, but that's not always the case. And it can be hard to tell just by looking at someone how bad their underlying disease might be. Just a few decades ago, the majority of babies born with congenital heart disease did not make it to adulthood. And now, really just since the 90s, there are more adults living with congenital heart disease than children. Mortality drops off dramatically after the first year of life and doesn't start to pick up again until the person is on average in their 40s or 50s. Despite, and maybe actually as a result of this progress, one of the major challenges in managing ACHD is recognizing and addressing its impact on quality of life. Many factors we know affect quality of life in this population, most obviously physical and cognitive impairments, but also psychosocial issues like mental health problems, altered relationships, and low self-esteem, as well as more systemic things like prognostic uncertainty and problems with the medical system. This brings up the point that ACHD care needs to be about more than just getting people to live longer, and that a focus on quality of life is just as, if not more, important than quantity. Many of these heavily psychosocial issues are just starting to be recognized in ACHD and are quickly changing the landscape for what is considered good care. One of the ways we can support better quality of life in ACHD is to utilize the principles of palliative care. So what is that? Palliative care is a type of medical care that focuses on supporting patients with serious illness and their caregivers. The core tenets of palliative care are promoting communication, such as about patients' disease processes, their values, their future goals of care. It's also providing, in particular, emotional and spiritual support, symptom management, and improving quality of life. Palliative care is appropriate at any age and at any stage of a serious life-limiting or life-threatening illness, helping people live as long as they can and as best they can together. Palliative care primarily benefits patients, but is also intended to support patients' families, and then also benefits to the healthcare system and society. Palliative care provides an extra layer of support for multiple dimensions of the patient experience. So in this pie chart, in the first domain, the physical domain, palliative care addresses things like pain, fatigue, dyspnea, sometimes things that are considered, beyond typical for a certain disease. In the emotional domain, it's anxiety, depression, it's coping. In the social domain, it's things like addressing caregivers' needs, supporting relationships, and addressing financial issues. In the spiritual domain, it's hope, faith, and finding meaning in the illness experience. And in the informational domain, it's things like addressing prognosis, facilitating illness, understanding, and planning for the future. In practice, palliative care falls into two major categories: primary palliative care and secondary or specialty palliative care. Primary palliative care can be provided by any clinician and involves the basic management of physical and emotional symptoms, discussions about prognosis, end of life, future care, and emotional support. Advanced care planning here on the left is thinking about the type of medical care one may or may not want if they ever become too sick to speak for themselves. It is recommended that advanced care planning occur when a patient is healthy-ish and stable and not facing the fear and distress of an exacerbation or an acute health event. Secondary palliative care on the right is typically provided by palliative care specialists, folks who have advanced training in palliative care. These can be physicians, but they can also be advanced practice practitioners, social workers, nurses, chaplains, etc. Secondary palliative care involves more complex symptom management, such as of refractory symptoms, concerns like pain, grief, and existential distress. It also helps patients and their families with conflict resolution, complex care coordination, and bereavement. When it was introduced in cancer decades ago, palliative care was what you did when someone had no further options for life-prolonging care, when it was time to move to hospice. But since then, though many may not know this, palliative care has evolved into more of a longitudinal process, initially occurring alongside life-prolonging care and ramping up as comfort becomes the primary focus. It is no longer equivalent to just hospice, and so we need to stop thinking and talking about palliative care as equivalent to hospice. The ups and downs of heart failure management, rather than any smooth trajectory, make palliative care, which is represented by the blue shading here, a little bit more challenging than in much of cancer care. This schematic for palliative care in heart failure was proposed in 2009. And as you can see, when functional status is poor, such as at heart failure diagnosis on the left, or during exacerbations in the middle, palliative care may become more prominent. And when things are stable, it may be less of a consideration, unless or until the person, for example, gets a heart transplant and establishes a new baseline, or proceeds to end of life. The two clinical trials that really put palliative care on the map for heart failure were PAL-HF and SWAP-HF. In PAL-HF, 150 patients with heart failure were either exposed to a patient-centered multidisciplinary palliative care intervention or usual care. In this study, they found improved quality of life at 6 months and non-significant reductions in total readmissions, as well as similar days alive out of the hospital. In SWAP-HF, 50 patients hospitalized with acute decompensated heart failure were exposed either to a social worker-led palliative care program or usual care. They found improved alignment of patient versus physician understanding of prognosis, as well as significant improvements in advanced care planning documentation and end-of-life orders. These provided evidence of positive impacts of palliative care in this population on both patient-reported outcomes and systems processes. And as you can see, palliative care is still a relatively new concept in heart failure. These intervention trials were only published about 5 years ago. And the cool thing is that they started a domino effect. And now just a few years later, palliative care is considered a core part of advanced heart failure care. It is recommended in both the American and the European guidelines. It's the subject of expert and consensus statements. And in some cases, like with destination beds, it may be required. But adults with congenital heart disease are not your typical heart failure patients. They're much younger and they're in a unique stage of life where they're exploring autonomy and responsibility for their health. Their bodies, their goals, their problems, and their responsibilities are different than the 70-something who is dealing with acquired heart failure after a relatively normal life. And they can often come with this feeling of having already beaten the odds, sometimes projecting feelings of invincibility, which can be really hard to manage. This is especially because of these rapid advances in care that I mentioned earlier, we have generational cohorts of patients, such that there's often no comparable patient who has come before. And this makes prognostication for this group really difficult. Taken together, clinicians, even at exceptional subspecialty centers, are often not necessarily familiar or comfortable caring for advanced disease in this group. We don't, unfortunately, find much guidance for palliative care in our ACHD guidelines, although they are generally supportive. In the 2008 guidelines, which actually was the first set of guidelines for ACHD, there was one bullet in the half-page section on psychosocial issues recommending that all patients should be encouraged to complete an advance directive, ideally at a time during which they are not extremely ill or hospitalized. You can see that this was a 1C recommendation, consensus opinion only, because no studies of palliative care in ACHD had yet been conducted. Between then and 2018, when the second set of guidelines was published, a handful of papers on advanced care planning in ACHD were published, 3 studies out of Toronto. And based on these, the 2018 guidelines say, discussion of end-of-life issues and advanced directives can be beneficial for patients with ACHD or their surrogates. Now, palliative care does get its own half page in these guidelines, but you'll notice that this recommendation is much less directive, likely because although the recommendation is now based on evidence, these studies were not clinical trials and they did not evaluate benefit. And there's limited mention in them of palliative care more broadly, focusing mostly on advanced care planning. So what did these Canadian studies tell us about advanced care planning? In a survey of ACHD outpatients, 87% thought it was important for someone to know their wishes if they became too sick to communicate. However, 56% of them had never heard of advanced directives, and 77% of them had never written down their wishes or thoughts about their future healthcare at all. Only 18% of them had appointed a power of attorney. There was limited self-reported ability of cardiologists to have advanced care planning and end-of-life discussions with their patients, and lack of clarity as to when and how to start these discussions. There was also a huge disconnect between patient and clinician or provider perspectives on advanced care planning. 50% of local providers reported having discussed end of life with their patients at least once, but only 1% of patients reported discussing end of life with those same providers. Less than half of providers reported a preference to initiate end of life discussions when patients were healthy, with increasing likelihood of doing so if patients had more severe or progressive disease. However, 62% of patients preferred engaging in these discussions when they were healthy and regardless of their disease severity, and even if they had a greater than 10-year life expectancy. Patients also wanted their providers to initiate end-of-life discussions, thinking that they would do so when it was time for them to start thinking about these things. Finally, in the only inpatient study to look at whether this type of care mattered, end-of-life discussions were documented for only 10% of patients who died, 6% prior to the admission where the death occurred, and 4% during the admission. Eventually, discussions were documented with 41% of those surrogates, but for the most part, these occurred in the setting of futility, on average 2 days prior to the patient's death. And the kicker here for me is that all of these deaths were expected. All of these patients were reported to be highly symptomatic and had previous multiple heart failure related admissions, and 42% of them had undergone transplant evaluations. As to whether or not these discussions mattered, patients who had documentation of an end-of-life discussion were less likely to undergo aggressive resuscitation at end of life. And even though less than a quarter of patients were referred for subspecialty care like palliative care, none of the patients who were referred to palliative care died under attempted resuscitation. So maybe some indication that palliative care could affect outcomes, even though discussions rarely occurred ahead of when they were needed. There since have not been any studies of palliative care as related to patient-reported outcomes, and there are no clinical trials. So that takes us to 2017, enter me. There was clearly a lot more to understand about this issue, and I had questions like, what are the palliative care needs in ACHD? Are there none? And the reason it isn't happening is because it isn't needed. But if that's not it, then why is it like this? And also, if there are needs, how can we improve to meet them? So we designed a few studies to learn more. We started with defining palliative care needs in ACHD by taking a retrospective look at healthcare resource utilization at the end of life, one of the first looks of its kind, for patients with ACHD in the UW system. And we compared this to comparable patients with cancer and acquired heart failure. We found high resource utilization in patients' last 30 days of life. 40% of patients with ACHD were hospitalized, and almost 40% had an ICU admission, and 64% died in the hospital. This finding suggests an opportunity for incorporating palliative care for these patients. Compared to the other groups, patients with ACHD were less likely to have an ICU admission than patients with heart failure, which we thought might reflect lower use of advanced heart failure therapies, either related to lack of candidacy or lack of opportunity, given the higher prevalence of arrhythmias and lower prevalence of acute decompensated heart failure as causes of mortality in this group. But compared to patients with cancer, patients with ACHD were significantly more likely to have inpatient and ICU admissions, as well as more likely to die in the hospital. And we thought these differences might be driven by variations in the use of palliative care between these two groups. Finally, we found that 41% of patients with ACHD had some documentation of advanced care planning. This was significantly higher than patients with cancer, which was surprising to us, but comparable to patients with heart failure. Unfortunately, we couldn't tell when the documentation was accomplished because of data limitations, so it could have just happened at the very end with surrogates, just like they found in the Tobler study. Right around that time, we also saw the first US inquiry of advanced care planning in ACHD, which was a survey of outpatients at Penn. They reported a similarly low prevalence of advanced care planning as the earlier studies, but slightly less of a patient-provider mismatch. There was patient interest in learning more about life expectancy and advanced care planning, but unlike the prior study, this was reported by patients with lower ACHD complexity and those with higher levels of anxiety. Anxiety has been recognized in this patient population as a common comorbidity, with up to half of patients experiencing it in some studies. And additionally, in response to earlier questions about when to initiate advanced care planning discussions, this study suggested they should start around age 18, but that they could start earlier depending on the readiness of the adolescent to engage in such conversations. Building on this, we designed an outpatient survey asking patients about palliative care and advanced care planning. About half had at least one hospitalization in the last year, some ACHD-related limitation, and had worries about their heart condition. Like the other studies, we also found similarly low prevalence of people who had previously engaged in advanced care planning, 14 and 29%. However, participants were very willing to discuss their care preferences, participate in advanced care planning, and even speak to a palliative care specialist if their ACHD doctor recommended it. Those who were married or who anticipated having shorter lifespans were more willing. We also identified key facilitators and barriers for participating in palliative care and advanced care planning. Top reasons for engaging were worrying about quality of life and being a burden on friends and family. Participants who had prior experience with serious illness, either themselves or with a friend or family member, were more interested. On the other hand, reasons against engaging were not feeling sick enough, not knowing which doctor would care for them, so who to talk to about this, not being ready to discuss these issues, and worries that their preferences might change in the future or depending on the situation. Many of these were in line with the Canadian studies. So we had some new information, but lots of questions, and we wanted to know more about what was driving these facilitators and barriers, and why, if patients were willing, palliative care and advanced care planning weren't happening. So we conducted a qualitative study of semi-structured interviews with patients, and we asked them these questions. 4 primary themes arose from our thematic analysis, and those are listed here. The first was using knowledge as a tool to combat future prognostic uncertainties. Participants talked about wanting information about what to expect and when to expect it. An exemplary quote is, "I need to know, oh, this could happen, this is normal. I want to be able to, if a decision comes up, have a sense of knowledge about it already to help make that decision." The second theme was unfamiliarity with and limited prior exposure to palliative care and advanced care planning. The majority of participants didn't know what palliative care was. There were many misconceptions, and overall it had a negative reputation. An exemplary quote for this theme was, "It sounds scary, and I would be scared if I hear that, because that's like hearing my doctor give up on me." The third theme was palliative care and advanced care planning are good ideas, but do not feel personally relevant. After we explained what palliative care and advanced care planning were, lots of people said something like, "Oh yeah, everyone should do that," or "Wow, I could get hit by a bus tomorrow." But then they very quickly followed those statements with, "Yeah, I don't really need to do this right now." An exemplary quote was, "It's hard to feel like you want to talk about it if everything's going okay. It doesn't feel like a priority." And the final theme centered on the importance of tailoring the timing and presentation of discussions about palliative care and advanced care planning to the individual. Participants wanted resources that were designed specifically for them and that were available in multiple formats like paper, online, discussion, etc. An exemplary quote for this one, and this is one of my favorites, was, if you give them something that has a gray-haired person on the front, I think it implies that, well, these are things we need to think about, but I don't really need to do it right now. The other thing we learned as a result of this study is that there probably is really no best time to start palliative care and advanced care planning discussions. Unlike the mean age of 18 recommended in the DANG study, which was the mean value found in their survey, we heard everything from bring it up when they're diagnosed all the way to wait until age 65. Often these recommendations depended on what else was going on with the patient's health and how mature or emotionally ready the patient might be to engage in these discussions. Our big takeaway from the study was a need for more education about these issues, but that they should be approached with thought and built into care early as a normal part of care so that they seemed less daunting. Now, I know someone listening is very concerned that these data are all from single centers. I am too, and I promise we're working on that. The first population level study was very recently published from the CH Strong project. This is a registry that includes all patients born with congenital heart disease in Arkansas, Arizona, and the greater Atlanta area. Like the prior studies, these authors also found a very low, actually lower prevalence of advanced directives, even in patients with heart failure. Those most likely to have advanced directives were generally older and had one or more disabilities or other congenital anomalies, so potentially worse disease. They were also of non-Hispanic white race and ethnicity. They were patients with insurance or those who had been recently hospitalized or had recent cardiology care. So overall, patients with more access to or touch points with care, reflecting the importance of interactions with clinicians in providing this type of care. Given this importance of interactions with clinicians, the last thing I want to talk about that in this section is shortly after completing the prior two studies and before this very last one was published, we decided to check in with clinicians. You'll remember the earlier study was of clinicians practicing in the Toronto area. So for this one, we conducted a study of clinicians attending our international ACHD meeting. About a quarter practiced outside the US, half had formal ACHD certification, and 55% had no prior palliative care training. And as you can see here, even though the majority would initiate advanced care planning and end-of-life discussions while patients were healthy, the severity of their disease played a role, and almost one quarter would wait until some complication arose. There were a number of barriers to initiating these discussions, which we actually collected using open-ended questions. The top barrier was that it might be too early to prognosticate. We don't know what's going to happen and we don't want to take away hope too early. The second barrier was concerns about family, that there was a lack of support either because there was or there was not family present. And actually, patients having young children was suggested as a reason not to discuss end of life with them. The third barrier was inaccurate patient knowledge about their disease or expectations for future treatment, making these discussions too onerous. As part of that survey, we presented fictional case presentations and asked clinicians about their comfort managing associated symptoms. The colors here are a little bit of a cold heat map, where greater comfort is represented by dark blue and less comfort by these lighter blues and gray. Not surprisingly, clinicians were relatively comfortable managing fluid retention and dyspnea for ACHD patients with advanced disease, but they were less comfortable with psychosocial issues like anxiety, depression, and patient expectations surrounding transplant candidacy. For 3 of the cases, we asked about other issues, which you can see were ICD deactivation, pain, and family disagreement. And you can see the striking lack of comfort in managing these concerns. In almost all cases, clinicians thought advanced directives were important in this first column, but they were all less comfortable discussing prognosis, and only rarely would they initiate advanced care planning themselves or refer to palliative care. So this left us asking, who's going to do it? And remember, the prior studies all showed that patients want and expect their clinicians, specifically their ACHD clinicians, to initiate these discussions. So what do we do with all this? There's a lot of potential here, but also a ton of holes. On the clinician side, for now, it's education and management. Engagement. Groups like the ACC and the ESC are working to increase awareness of palliative care and advanced care planning for this population. I've had the privilege of being involved in some of these efforts, and I think we'll be hearing a lot more of this coming soon. But for the rest of our time together today, I'm going to shift gears and talk about one approach we're taking to use palliative care to support patients with ACHD. So that brings us to part 2, a focus on quality of life, resilience, and ACHD. In our qualitative study, even though we asked interview questions specifically about patients' experience with palliative care and advanced care planning, almost everyone talked spontaneously about the long-term impacts of having ACHD on their adult lives. Like, this was a huge part of their story, and they just needed to tell it to us, even though we weren't asking about it. There were effects on their sense of identity, influence to the decisions they made as adults, like what kind of job to have or whether to have kids, and how living with ACHD was at times a source of psychological distress. This included concerns that they had a lack of skills to cope with chronic illness and to manage uncertainty. So we started thinking more about how to address these concerns, which all seem to center on quality of life. One aspect of palliative care, which is often called upon to empower patients as they navigate through serious illness, is the idea of resilience. Resilience is recognized in many fields and used in a variety of ways. But in health psychology, one definition of resilience is harnessing personal resources to sustain physical and emotional well-being in the face of stress. It is often referred to as bouncing back from a challenge or someone having grit. A person's baseline resilience may be somewhat inherent, but it is a process in that it can be developed and strengthened both through life experience and targeted education. A person goes through 3 overlapping phases of resilience when facing a challenge. Perhaps the first and most instinctual is getting through whatever the challenge is. Having survived the initial exposure, then the person can begin to harness resources within and around them to begin to move forward, eventually being able to look back and learn from the experience. Areas of overlap between these phases representing the process are assessing ourselves, appraising the situation, and building identity and purpose. Harnessing resources, the part between getting through and looking back, means calling on the things a person has within or around them for help. These resilience resources seem to be universal and generally fall in one of 3 categories or buckets as displayed here. The first bucket is internal or individual resources, things like stress management and setting personal goals. The second is external or community, things like social support and who provides it. And the third is existential, issues like spirituality or faith and making meaning of the challenge. Why did this happen to me? And to what extent each of these buckets works for an individual varies depending on the situation, on that person's needs at the moment, and on cultural and societal influences. Going back for a second to the factors we know affect quality of life in ACHD, a similar concept to resilience is sense of coherence. Sense of coherence is a concept that comes from Antonovsky's salutogenic theory about promoting health and well-being, rather than solely recognizing and responding to disease. People who have a strong sense of coherence view their lives as comprehensible, manageable, and meaningful, as informed by life events and the perceived resources available to help them process those experiences. This in turn promotes coping, which influences health, which we can measure with clinical and patient-reported outcomes. In 2006, sense of coherence was suggested as a way to support psychosocial health in ACHD, starting in childhood and gradually increasing involvement to adulthood. Combating uncertainty with education is a way to promote comprehensibility, so it was suggested that parents and clinicians prepare the child with congenital heart disease to deal with this disease as an adult. As an aside, using knowledge to combat uncertainty was our first theme in our interview study, which arose completely separately from our knowledge of this model. Finding adequate balance between stressors and perceived resources is a way to promote manageability. So it was suggested that parents and clinicians provide the person with congenital heart disease specific support from the trauma of growing up and living with this disease. And finding ways to help life make sense and having the motivation to do so promotes meaningfulness. So it was suggested that the patient with congenital heart disease be invited from an early age to participate in shaping their future, and that steps should be taken to teach appreciation for the little things, gratitude, and address any existential feelings that arose. Sense of coherence has since been studied in ACHD and found to be associated with quality of life, as I've said, but also with perceived physical and emotional health. And a degree of personal control, perceived personal control over a situation emerged as sort of an umbrella concept that separated people with strong versus weak sense of coherence. Sense of coherence is worse if people are of younger age, lower education, people who are unemployed, non-partnered, and in those who have lower NYHA class. Not super surprising, since these characteristics tend to track with poor quality of life and, more importantly, less control. Interestingly, though, sense of coherence was worse for people with simple or minor ACHD. And the suggested reason for this was perhaps these people have not faced as much adversity related to their heart disease and therefore haven't needed to rise to the occasion. The sort of takeaway from these studies of sense of coherence is that examining it may help identify patients at risk for poor health outcomes, and it may facilitate timely referral for psychosocial care. So how are sense of coherence and resilience related? These have both been proposed as strongly overlapping but distinct concepts. They both contribute to the development of good health. Resilience describes the process of what facilitates people bouncing back after a challenge, and sense of coherence describes the outlook that facilitates people moving forward in terms of their mental health. Where they overlap, in the middle, the purple, is that both of these act as mediators between trauma and the person's subsequent emotional health, specifically the development of depressive and anxiety disorders, or DAD, in this diagram. Sense of coherence has also been proposed as a mechanism by which resilience is developed and as one of those internal resilience resources. So returning to the broader concept of resilience, what do we know about it in ACHD? The answer is not too much. I'm aware of only a couple studies of resilience in ACHD and 2 in adolescents. I won't talk about the adolescent studies today because adolescents have very different social situations than our adult patients, and we know that resilience increases with age. Maybe that teenage strife is good for something, but in these 2 cross-sectional survey studies of adults, adult patients with ACHD had comparable or higher resilience versus similarly aged peers without congenital heart disease. And congenital heart disease severity was negatively associated with resilience only in patients who had poor functional status. Resilience was associated with higher religiosity, so getting back maybe to that existential bucket, and with health-related quality of life. These papers suggested that since patients with greater resilience had greater health-related quality of life, it may be beneficial to implement interventions to foster resilience. So folks have started to think about resilience as an intervention target in ACHD, but as of yet, nothing has been proven. There are 2 studies that used behavioral interventions to decrease psychological distress and increase coping, but they do not go as far as discussing effects on resilience. A 3rd study reported that patients who participated in a 3-hour intervention had higher post-test resilience scores, but their analysis was relatively superficial, and their program was not previously validated as effective. There was also no discussion of whether this was truly a change in resilience or just something like confidence, since patients had just been newly exposed to these concepts. Another thing to think about for all 3 of these studies is that these interventions were all delivered in group format, and given the somewhat private nature of vulnerability and distress, some patients may prefer one-on-one interventions. So this brings me in these last few minutes to briefly discuss my current scholarship. In an attempt to broaden our understanding of what resilience looks like first in ACHD, we're simultaneously conducting 2 prospective studies, one survey-based and one qualitative. We'll be looking at prevalence of resilience and how it changes over time, as well as how it is related to other issues of interest, such as health-related quality of life, of course, psychological distress and coping, and the influences of key social determinants of health. Ultimately, we plan to use this information to pilot a previously validated one-on-one resilience building intervention in ACHD. Our qualitative study is far enough along for me to share some preliminary results. About a 1/3 of the participants we interviewed with were unfamiliar with the concept of resilience. Those who were familiar tended to be teachers or work in the social sciences. Yet every person we talked to described resilient actions that they take or have taken in managing their ACHD. Participants cope with having ACHD using a variety of techniques. These seem to fit best, I think, into a task versus emotion versus avoidance oriented coping model, but they also mirror the internal, external, existential model of resilience resources that I mentioned earlier. Participants' coping mechanisms have changed over time and depending on the situation. For example, participants described forced changes to how they cope as a result of COVID pandemic restrictions. Time and the perception of whether or not one has time arose as a major theme. Moving forward and finding ways around or past limitations is a prominent resilience strategy. And childhood experiences with adversity seem to strongly influence participants' coping strategies in adulthood. Participants were also almost unanimously in favor of participating in a resilience building intervention, and they felt that such an activity would be helpful in teaching them additional methods for managing stress. So I'm going to stop there and invite questions in a couple minutes. I look forward to having additional data to share with you at a future point as this field continues to grow. I hope I've demonstrated that quality of life is an important focus in ACHD care, at least equally important as helping patients live longer. I also hope I've demonstrated the value of incorporating palliative care into ACHD care to support patients' serious illness needs. And I hope I've given you a sense that resilience shows promise as an intervenable method of supporting quality of life and other psychosocial issues in ACHD. I truly believe that this area has great potential and that we're just getting started. I certainly couldn't have done any of this alone, so thank you to all of these people, to the Cambia Palliative Care Center of Excellence at UW, the PCAR group at Seattle Children's, and the Division of Cardiology, including the CTU and my awesome research staff and volunteers for their support. I'd like to thank my excellent research mentors for their constant encouragement, for always having my back. And thank you to the Division of Cardiology, the ACHA, the NPCRC, the ACC, and the NIH for funding my research. And finally, shout out to Dr. Gina Kang and Sharon White, who are leading clinical palliative care efforts for all patients cared for in the Heart Institute. So please consider referring your patients when they need it. Thank you so much for your attention.
Thanks, Jill. That was just such a fantastic talk. And I think the work you're doing is not only interesting, it is incredibly important. And I've been privileged to be a part of your research mentorship, and what I'm really impressed with is I'm ancillary to the process, and so I get to watch the experts do their work of really applying science to something, like everything we've learned about science and how to study things, and methods, and everything else, to something it's a bit on the squishy side. And one of the things that keeps coming up recently is that added layer of the resilience that the entire planet has needed in regards to the pandemic. And maybe you could speak a little bit to the combination, two things, either of them you want to, while we're waiting for other questions to come in, of any of the challenges that you've seen, but also the resilience that has manifest through the course of the pandemic in your research, whether it's your own resilience or that of the patients. And then whether or not you see an opportunity in the future to translate some of this to those tangible, cost-driven things or other stuff that health systems, insurers, the economics of medicine really seem to cotton to, because there's also a notion that not only are people's lives going to be better for being resilient and for involving palliative care, but the entire healthcare system may be a bit less expensive for it. So those were two wildly divergent questions. Tackle whatever you'd like.
I'll try to answer them both. They're both great questions. Thank you. Yeah, resilience has become a buzzword in these last 2 years. I think lots of people know what it is now, and they certainly didn't before. Part of the timing, we had to start and stop our interview study over the last 2 years with some of the restrictions and what people are up to and present or not. And part of the timing and decisions we made surrounding, how many patients to interview and how many times to go back to them or when to schedule those interviews was experience with the pandemic. And we did see some differences in how patients in these last few interviews started talking about resilience. These last few interviews seem to be a little bit more rich and reflective. And we're wondering if that maybe has something to do with this being more of a conversation just in the world. I don't know if anybody watches the town halls that DOM puts on, but there's a lot of talk of resilience in there. There's lunch lectures about resilience and well-being for faculty and staff. And this is a conversation that's sort of all over the place now, and it definitely wasn't 5 years ago. So I think that will continue to grow. The second is you asked about linking back to tangible things like cost.
Well, yeah. Whether or not there exists already, and Jim has said something in the chat, but exists, or you can see a path forward where this also has a beneficial impact on the economics of healthcare.
Yeah, And I think that's the next thing that we have to do to make sure that this grows appropriately, not out of proportion, but also doesn't get pushed to the corner. I think anecdotally, everyone involved or who has received this care feels like it's worthwhile and feels like there's a lot more that it can do, and a lot more needs. I think there is a recognized shortage of palliative care resources, clinicians available. Lots of places don't have any access to palliative care. And one of the only ways that we're going to be able to grow that is to be able to show its value in terms of dollars and people, which are, those can feel like cold things to talk about, but at the end of the day, they're the way things keep running. I think one of the things that makes me super excited about what the Heart Center is doing right now is that they brought palliative care back. We had for a little while on a pilot the opportunity to have some psychosocial support in our Heart Center. We lost it. And what we saw was patients really upset and frustrated with that lack of resources. And so I think we're starting to hear from patients that this is important. So what we need to do now is study that. We need to return back to do more than just describe how cool palliative care is to, what its actual impact can be in terms of outcomes. And the studies I didn't talk about that do exist out there in heart failure and cardiac care in general are things like we can prove that with interventions, we can get more advanced directives signed and we can get more, palliative care consultations done, but no one has still really made the leap to value of care. And so those are the things that definitely need to happen next.
Awesome. All right, so I've got a trio, 2 questions and a comment. So Jim says, fabulous talk. Do you think that focus on resilience and advanced directives might solve part of the problem we have with the bad rep of the term palliative care? And also then adds as a recent PA study of heart failure patients getting palliative care consult versus none did show a reduction in readmissions. So the bad rep of the term palliative care, do you think it's getting advanced by focusing on resilience and advanced directives rather than hospice?
Yeah, I think a lot of this is changing people's articulation and sort of the semantics of how people talk about palliative care day to day. And some of that is just growing out of thinking about it as hospice, which is why I brought it up. And yeah, I think talking, like we've found with other disease processes and types of care, when we focus on positive things, we get more positive results than when we just focus on negative things or bad things. And so thinking about ways to empower people, to help them, to support them, rather than to, wait until there's nothing else to do or like stick your head in the sand, I think will have a positive effect eventually. Helping people think about their future care, such as with advanced care planning and advanced directives, gives them an opportunity to think about things when they're not freaking out. And it can be really hard to think about what somebody might want until they find themselves in the middle of that that situation. But if they haven't thought about at least what's important to them and who is important to them, then people get left out, and people feel like they don't have the opportunity to leave a legacy behind or address some of the things that are important to them, but sort of in the background because of the pressing important things of day-to-day life. So yeah, I do think that focusing on these more positive terms and problem solving and thinking ahead will assist with that bad rap. There have been conversations of changing the name of palliative care. Some programs around the country don't call their teams the palliative care teams, that call themselves the advanced support team or something like that. Lots of cool acronyms out there. But ultimately, there's also an argument that we can't just, abandon this name that we created for the fields. We need to figure out how to translate it in people's minds to what it actually is now and get rid of that, outdated definition of it.
Okay, that's awesome because it's going to lead in. Stephanie, I'm going to get yours next, but I want to make sure that Randy Curtis's, there's a lead here. Great talk, Jill. Can you mention your upcoming pilot RCT as an example of what interventions might look like?
Yeah, sure. Thank you. So I didn't want to talk too much about it because, I realized this isn't a research conference, but the upcoming, what we hope to do with these first 2 trials is really understand a little bit more about what resilience looks like in our population. We've gotten a great start by some of the folks that have done this work, but you know, of course, like with any first 2 or 3 studies, there's inconsistencies. We need to be able to reproduce results and try to understand a little bit more about the processes and underpinnings of what those results are. And so that's what we're doing in these first few studies, first 2 studies, the first few years of my K award. And an example of what we can do then with that information is we're taking an intervention called PRISM. It's promoting resilience and stress management. It was developed at Seattle Children's for initially adolescents and young adults with cancer as a way to build resilience for those patients and support them in going through their cancer experience. It was, you know, it was a really rigorous development, going through a lot of different levels of concept development, a lot of patient involvement in creating the program. It was ultimately proven effective in that group, but then also in the parents of that group. And then also in patients with other types of chronic illness like type 1 diabetes and cystic fibrosis. And so there's a lot of opportunity here, I think, for translation. What we're doing right now is trying to think about how we might need to expand or tweak the program to make sure that it's specific for the individual groups using it without diverging too much from the core principles of it. And so our hope in being able to pilot that in our patient population will be that it can address some of those needs that were brought up in specifically the interview studies.
Awesome, thank you. So for those who are putting in questions, I'm going to get to reading all of them. I've been instructed that that is a more effective and efficient way to do this rather than having folks hop in and ask their own questions. So if you have one, if you could type it in either to the Q&A or the chat. Right now I'm working through the Q&A and I'll get over to the chat in a second. Stephanie says, amazing talk, Jill, really important work. I'm confident that though this population is unique, your findings will be generalizable to other groups of patients. Getting back to adult care, ACP, I am not surprised that patients expect their providers to talk with them about what to expect, nor that the providers are not doing it. Besides printed materials telling us how to do it, how can we, or telling us to do it, how can we lower the barriers to getting providers interested, willing, comfortable to talk with patients in this manner, given that it improves overall care? And I'm going to piggyback off one of those people, assuredly, who thought they had the conversation, the patient didn't perceive it. So add to that of like, and also how do you get patients to know that that's the conversation you're having? It feels a little like the, hey, we're giving feedback concept.
It's a lot like that concept. Yeah, thank you. And Stephanie, I was actually going to say at the beginning that a lot of what I was going to talk about today was applicable to other groups, even though some of the uniquities of our patient population don't translate. But you're right. Advanced care planning is used everywhere, and it's not a super narrow concept. And we've created a healthcare system where, you know, we're trying to get away from it a little bit, but it's still a very paternalistic system of like, we will tell you what to do when it's time. And like, don't ask us about it before then. And even when patients go out, and I do this too, they come in with like 30 pages off the internet. You're like, no, we're not going to talk about that today. We're not doing that. But it certainly sets up the situation for, just like a patient wouldn't necessarily ask about care that we're not doing right now, either because they don't know about it or because, you know, they don't think it's for them right now, is because of the model that we've imposed on them. So we need to be more forthcoming in incorporating advanced care planning as part of the conversation, just as we do, you know, laying out the map of, you have a diagnosis and now here are the things we're going to do. One of the things we're going to do, in addition to whatever the medical treatments are, is talk about how this might go. Certainly how you want it to go. What are your hopes? What are your fears? What are your worries? To make sure that our care is aligned with what you value. And then part of that, what we're going to do is, you know, even if they change later, you're not backed into these choices forever. We're going to ask you to think about what you might want or not want if things don't go the way you want them to, or if we find ourselves in certain situations. The challenge is being able to describe those situations in a way that feels real and tangible to patients, right? Someone who's never been on a vent, on ECMO, has no idea what that feels like. And what we've seen with so many of our patients is that there's no way to describe that feeling to them in a way that can help them make actual realistic decisions. So it's going to be baby steps of sort of the way resilience has crept into our conversation these last 2 years. I think we need to do that with advanced care planning. There's a lot of controversy as to what to do with advanced care planning right now. But I think the overall agreement is that we can't abandon it completely, and we need to think about how to use it as an actual tool and not just jargon. So going back to your question, like one of the ways to do that is to get people invested in it. There are, a few studies specifically in heart failure, one actually done here that I didn't talk about, that helps providers talk to patients about these issues. I think they gave like an advanced care plan document to patients and providers, and then the clinician had the opportunity to review what the patient filled out ahead of time with the intention of having a conversation then in a clinic visit. And there's a number of studies also through the Cambia Center right now that are doing this in other populations. And it's that sort of thing. It's just getting patients engaged. It's giving them the language that is going to get us to be able to use this stuff in real time. So printed materials, sure, but educational programs, there's been a call for training in this from cardiology fellows and also fellows not in cardiology. Other subspecialties want this as well. And things will get built into training. Until we get there, it's going to have to be taking the initiative, recognizing that this is something our patients want, and this is something that can help our patients. And therefore, it is our responsibility to learn at least how to have these primary initial conversations with them. And when we get stuck, hopefully, like here, we have the ability to ask for the help of our specialty colleagues in palliative care to continue those conversations. And what we can't do is stick our head in the sand and do nothing until like 2 days before our patient's dying and everyone's in the room, in the provider room, being like, no one wants to talk about it, because that's not good for anybody.
No doubt. I've got a series of things, and I think you may have addressed a couple of them, and I'm going to go a little backwards. Great work, Jill. Very important in these vulnerable populations. Aligns closely with other heart failure, with cardio and cardio-oncology cohorts too, that would benefit from individuals like you. That's from Richard. Larry, outstanding talk and discussion. Not a very nice talk and impactful work. The question, and you may have addressed some of it just now. Gwen says, wonderful presentation, Jill. Could you speak to the recent controversy surrounding advanced care planning and how and whether that is impacting your work in ACHD and resilience? And then Abby also has something along those lines of, Jill, terrific talk. You shared the value and mixed opinions of young adults regarding advanced care planning. How might resilience interventions enable ACP comfort or process among young adult patients? And I think you've kind of talked about that. Maybe Gwen's question is an expansion of what you were just mentioning. Have at it, and then I'm going to switch to the other.
Yeah, so there is some controversy about advanced care planning, and I'm still not really sure what the answer is. As many people, so this came up recently because one of the folks who really started studying advanced care planning years ago recently published a few things that said like advanced care planning has failed, and that we shouldn't focus our efforts on it anymore. And what it has done is sparked a discussion of what actually is advanced care planning. What does it mean to people both within the palliative care community and outside the palliative care community? And I think where we're landing with this, although lots of conversations upcoming, is that, I don't think we can abandon it. We need to make sure that we're using the actual intention, the conversations, and what we meant to accomplish by creating the phrase advanced care planning for what we intended it to do. It can't be just like a perfunctory look at what patients might want with no follow-up. It can't be like, oh, good, they got that signed document in the chart, so we're done here. It has to be an ongoing opportunity that allows them to think about, as things change in their life and they're faced with new questions, treatments, options, or lack of options, an opportunity to think about how each of those things may or may not fit with them. And so maybe it will morph into a little bit of goal concordant care and aligning with their values, even though that is really hard to measure. So I'm not really sure where we're going to end up with it. But in terms of how it's impacting this work, I think it has caused me to deviate a little bit just from looking at advanced care planning, but to expand the way we're thinking about these things and what goes into that process, and what gives people the ability to plan for the future rather than just getting them to fill out the piece of paper.
Awesome.
Yeah.
Let's see. Is it possible from Milish, to put together a team of high resilience patients as coaches and encouragement for other patients? And somewhat similarly from George, have you studied the group therapy and cardiac rehabilitation where patients with like diseases are able to help each other? So I think both of those speaking to the idea of essentially peer counseling.
Yeah, so no, we have not specifically studied that, but it is absolutely one way this can happen. Just like in other types of challenges, some people like to work alone, some people like to work in groups. Patients with ACHD also have similar preferences. Lots of them do ask, I think because of that generational difference in terms of like, what's going to happen to me? And our answer is like, we don't really know. There is always an ask for like, can I talk to someone else that's like me? Can I talk to someone else that has gone through something that I might be facing in 5 years to know what to expect? And so, yeah, I think there is an opportunity to, use groups, or at least have the option for people to talk to other people like them in terms of processing some of these issues. The internet does this really well. And so an example I'm going to use to counter that for a second is like a Facebook group of like people with congenital heart disease can be a really great opportunity to like ask your questions and make connections, but it can also be a really great opportunity for like negative rumination and getting completely freaked out by all the bad, because we know as humans that we're more likely to talk about posts, etc., our bad experiences and our frustrations than the good ones. And so I think we need to be really careful and intentional when we're setting up group opportunities, what goes into those conversations and how we're guiding them to make sure that they end up as positive experiences, or at least neutral experiences that accomplish the goal of getting people together rather than letting them deteriorate into something negative. But yeah, one of the discussions we're having is how can we have an option that is group oriented for folks who would prefer that, at least after they learn the steps of resilience and some ways that they can bring those skills to the table.
Awesome. I think that is we got to really enjoyed the talk. Thank you. So I think that's a fantastic sort of last comment from the group. There is somebody who's an anonymous attendee who is an advanced heart failure trainee and really keen to pursue palliative care and is interested in your journey. So I would suggest anonymous attendee, maybe reach out to Jill directly, because I know some of the details of that journey are what's going to be super important, and that's probably best done one-on-one. So Jill, I really want to thank you, not just for taking the time to present your scholarship, your work, and your professional passion for this, but frankly for doing it. I think it's incredibly cool that you're doing it. It's going to benefit us and our patients. And it's also just great to watch somebody get a chance to do the things they have a passion for and really succeed at them. So congratulations to you for all the success you've had so far. I didn't go through the litany for everybody, but it's robust. And it's been a delight to have you as a colleague, and I'm looking forward to more in the future. So thanks everybody for attending and for all the questions, and we'll see you next week.